morning. Thank you for having me. It's great to be here in Seville and be part of this two-day symposium. I will try to follow up on Katya's work in some parallel ways. By and large, what I want to spend the 2 hours discussion today is what is chronic pain? This is really the question that I want to sort of begin to pose and keep developing it. We've been asking this question for more than 15 years, and we will probably keep asking it for a lot longer to come. On the other hand, the good news is that we have, I think, made some important progress on the topic, and the old classic ideas of what is chronic pain are not valid anymore. Very much along the same lines that Katya was saying, we think that the brain has a very critical role in the chronification of pain itself. And that's the overall message that I want to leave you with. I will show you lots of data, and I apologize. I am also a basic scientist. I love numbers and I love the data themselves. But the big message is very simple. There's a big revolution coming up in our understanding of what is chronic pain. And that revolution, I hope, in fact, will translate into better treatment and better outcome for patients as well. And along those lines, I'm very excited with, in fact, the brain imaging field itself pushing the whole concept forward. So I don't have to apologize what the pretty pictures of the brain show. They actually are showing us the way forward about how we treat patients, how we consider patients, etc. Anyways, and also, in fact, my computer crashed this morning, so I have reassembled my talk. So if I stumble here and there, I apologize. If I can just start with. Okay, so I want to start with René Descartes, a wise person who in 1644 drew this picture. And in many ways, pain scientists at least have always loved this picture. And the picture has given us a very important message. This is the first concept of a sensory system. And Descartes illustrated for pain itself, and so it's appropriate to give him credit. Essentially, what he's showing is that there is a stimulus, and that stimulus is encoded at the skin level. Transmitted somehow up all the way to the brain, and the brain perceives it. So all the fundamental components of sensory representation was presented to us back in 1644 by René Descartes. And in many ways, over the last 100 years, pain research has been trying to establish this, to establish the components of this system. What is the encoding process? What are the channels? What are the receptors at the level of the skin? What happens in the spinal cord? And then how is that information is transmitted up to the cortex? In parallel to that work, and that work has been fantastic, and we have in fact very beautiful evidence along those lines. There is no question that pain is a sensory process of its own that has all of these pieces that we have already established. However, on top of that, what we have been seeing is a reorganization of the system as soon as the painful stimulus becomes persistent. As soon as the pain stays there, we have local reorganization of the tissue and local sensitization of the tissue with various receptors upregulating and even genetic changes at the level of the dorsal root ganglion. Similarly, we now have what is called central sensitization, and I'm hoping that you all at least are aware of the term. Essentially, all what it says is that when the painful stimulus is persisting again, the spinal cord circuitry has reorganized to enhance that signal, the incoming signal. So a stimulus that was not very painful in the normal tissue is now being transmitted at a higher rate, at an amplified rate, at the level of the spinal cord. Well, what I want to talk about is, in fact, something above that, in a sense that what's happening at the level of the cortex, and our work and many other labs nowadays also show that there is a reorganization of the brain itself with persistent pain. There is anatomical reorganization of the brain and functional reorganization of the brain, and that reorganization we now assert is, in fact, the transition from an acute pain state to chronic pain. So that's the overall message I wanted to give you, and what I would like to essentially discuss are the properties of this reorganization in the first hour of my talk, and in the second hour what I would like to go over are the mechanisms that we are beginning to unravel of the transition from acute to chronic pain, and what are the risk factors, the predictors, and the consequences of the transition from acute to chronic pain. So the definition of chronic pain itself is tautological. All it says is that it's pain that persists, which is maybe a smart thing to do in that we leave to the future how to define it mechanistically. But I think it's already time for us to start asking that question. Can we mechanistically define what is chronic pain? And in fact, both the basic research as well as the clinical concepts of chronic pain remain until today very much within the realm of the nociceptive system. We probe them, we touch them, we ask them where is the pain, how is the pain, and we keep hoping that if simply by better characterizing the nociceptive properties of the pain, we would understand chronic pain itself. So at least our current bias is that that may not be as helpful as we would have liked it to be in the past. That we have to ask more probing questions. For example, some of the questions that Katja was posing, the past history of the subject, the emotional state of the subject, all of things like that. So here's a definition of chronic pain that we propose, and it is a challenge, and over the next couple of hours I will try to sort of justify this definition. What I want to say is that it's pain that engages the brain emotional circuitry and the learning properties of that emotional circuitry, and reorganizes what is the value of pain. That's a very general statement in many ways, but I think we have the components of this that are being sort of worked out. Okay, so for the next hour, I want to just spend some time showing you the evidence that acute pain and chronic pain are not the same. They're not the same anatomically in the brain. They're not the same physiologically in the brain. And I will show you multiple different lines of evidence of the differences between the two conditions. And also, I'll show you some of the data, for the most part, because I'm excited because of some of these recent results that we have about actually how strongly a predictor the brain is about the future. The brain predicts the future. It's a survival machinery. And so we can simply look inside the brain and predict who is a placebo responder and who is not, who is a specific drug responder and who is not. I want to share some of that data with you. So, and then there's another very broad discussion that has been happening in the field of at least brain imaging in general, and that is at what level do we understand the brain? This is a discussion that, in fact, probably started with Nobel Prize winners Cahal and Golgi when they were discussing what their findings were. Cahal got the Nobel Prize for identifying the single neuron, the element of the computational element of the brain was the neuron, right, with all of its axons and its dendrites. Golgi, on the other hand, criticized Cahal, saying, what are you talking about? The brain is a network. Everything is connected. How could you ignore the interaction and talk about a single neuron? Well, that discussion is still ongoing. We still discuss this. And in a sense, we can present evidence at both lines at the same time. And I'm an agnostic. I believe whatever the data shows me. I don't think I can a priori make a decision of what is the computational level of the brain. So I will show you evidence along both of those lines, although I think when we think of the brain from a viewpoint of pain perception, what we're talking about is consciousness, right? Pain perception is a conscious state. So that has to have a highly integrated brain state. So when we're talking about specifically understanding perception, I think we have to incorporate the brain as a network as part of the overall system. Anyway, let me move on. This is a slide from a paper we published I think probably 10 years ago or so. What I want to emphasize here is that pain is not a static state. We ask the patient, how much pain do you have? Okay, how relevant is that question for the pain that they had 10 minutes ago versus an hour ago versus a year ago? And we've done this very simple metrics. In this case, I'm showing you 4 different pain rating tasks from 4 different chronic pain patients. In each case, the subject is rating their pain continuously, simply using their finger, right? So we tell them if your fingers are closed, you have no pain. Your fingers are completely open, you have maximum pain. Now tell me how much pain you have for the next 10 minutes. And you can see that the pain continuously fluctuates over a 10-minute time scale. Not only does it fluctuates in different ways for different chronic pain conditions. These are back pain patients, post-herpetic neuropathy patients, thermal pain, and these are subjects who have no pain and they're trying to fake me by trying to move their fingers in a way that would, look like they have pain. Well, if we simply look at the dynamics of these systems, we can completely tell them apart. The chronic pain patients, different types of chronic pain patients have very standardized, nonlinear, fractal structures. Doesn't matter. All it means is that the variability of their pain has a signature that we can capture, and it's uniquely different for different types of them. The plot here are for 2 osteoarthritis patients over 3 months. They're rating their pain 3 times a day. And you can see that the pain goes from 0 up to 8 continuously. So we have to take the temporal variability of the pain into consideration when we're looking at these conditions. Okay, and in fact, over the last number of years now, we have been studying brain activity for chronic pain patients using such an approach. Rather than giving a patient an acute painful stimulus, which may or may not have anything to do with their chronic pain, we instead ask the subject, tell me how much pain you have right now, continuously. So again, we use this simple finger device. The subject says, I don't have pain if they're touching, or they move it all the way up, and they move it up and down for 10 minutes. We put them in the scanner while they're rating with their finger their pain, and then we use that as a vector to identify what brain regions are associated with that. So we're actually looking at the variability of their pain, at their subjective variability, and its brain activity. If we do that on a group of chronic back pain patients, we essentially identify activity in the medial prefrontal cortex. So this was a paper, published about 10 years ago. I'm showing you this data in comparison to brain activity that's based on a meta-analysis of 224 pain studies. Okay, so this is simply taking from the PubMed, the literature, 220 pain studies, averaging all of the brain regions that are activated, and this is the map that they get. This region of the brain is not included here. So either we're doing something wrong, or there's a mismatch. The mismatch is that these studies are all for acute pain, and this is for chronic pain. So the point is that acute pain has a sensory representation, which is relatively standard. That's been shown across many, many labs. You can think of this map as a map of 2,000 people averaged altogether. Okay? So, yet that map does not show anything that has to do with the chronic back pain. On the other hand, if we simply take the activity in this region and plot that activity in relation to the pain intensity that each subject says, we get a very nice correlation. So that in fact, the specific subject's back pain intensity is nicely captured in that region of the brain. So given that we see a mismatch, we've tested this in multiple different ways, and in this case, this is now another set of chronic pain patients, chronic back pain patients, looking at the same brain regions, and again, we see that this medial prefrontal cortex very nicely correlates with their spontaneous pain. Another area of the brain, the insula, does not. On the other hand, for an acute thermal painful stimulus, this region correlates very nicely with the intensity of the pain, both in patients and in healthy subjects, but shows no correlation with the intensity of the spontaneous pain in the patients. So this is a double dissociation in a sense that we see one brain area related to the pain of the chronic pain patient and another brain area to the acute pain, even in the same subject. Okay? So the dissociation is within and across subjects. And now we have done this in a large number of different chronic pain patients. This is, in a sense, the soup of chronic pain. What I'm trying to show you is that there are multiple different signatures of chronic pain. Each one of them shows up with a different brain activity pattern. Overall, there is a shift away from sensory regions of the brain into more limbic and emotional and prefrontal cortical areas. Right? Yet, the signature seems to be very specific to each condition itself. It's hard to see in all of these cute pictures that Katja is going to deconstruct later on, I think. But for example, if I take just the medial prefrontal cortex, you can see that, I can't see what the writing here is. Anyway, the different chronic pain conditions show differential brain activity. In the prefrontal cortex, in the amygdala, thalamus, in the insula, each one of them, we can see that there is a specific pattern that differentiates the chronic pain conditions. So not only is chronic pain different from acute pain, but different types of chronic pain give rise to different signatures of brain activity, localized brain activity in the brain. And this essentially shows the same data. Again, if I simply look at this region of the brain, that region is consistently high activity in the chronic back pain patients, but not in these other chronic pain conditions. Here, each dot is an individual subject, right? And so the activity is both specific as well as sensitive, in a sense. Let me go on. So, again, about 10 years ago, we published this paper showing that, in fact, the brain anatomy is different in chronic pain patients. This is the study that showed that both bilateral prefrontal cortex and the thalamus has decreased gray matter density. So in a sense that the local tissue density is lower. Exactly why that is still remains a debate that's ongoing, and the details remain to be uncovered. But since that study, there's probably more than 100 studies now showing that all very different types of chronic pain conditions, each one of them is associated with a variety of different patterns of brain anatomical changes. This is the pattern. These are old slides. There's a lot more data nowadays, but this is in fibromyalgia, for example, the brain regions that show differences in gray matter density. This one is in tension headache. This is from Germany, and this is from Canada, irritable bowel syndrome patients. And in many ways, this literature has become rather confusing because every day we have another picture of another brain area that's gone up or down in its gray matter properties. And I hope to convince you that there is a better way of looking at this in the next few slides. The other important part of this work has been, this is from Dave Seminovis's study, in that when you take chronic back pain, chronic pain patients, and you properly decrease their pain, many of the changes in the gray matter properties seem to be reversed. I don't know if many, but at least some of them do. And this is an example of that. This is again the gray matter regions that are decreased in density prior to treatment. With successful treatment, you can see that at least this specific area, this lateral prefrontal cortex region, is increasing in its density. It's recovering back to the normal state. And this recovery in many ways, at least to me, implies that what we are looking at are macroscopic signatures for the synaptic reorganization of the cortex. So we think of this as essentially showing us what is the synaptic profile of the cortex in these patients, and it's changing because of the suffering of the patient with the condition, coping with the condition, etc. I'm sorry, I have no idea how I'm doing on time, but it's okay, we'll figure it out. So here is another way of looking at the brain anatomy, and I want to spend a few minutes discussing this with you because it's a fun idea, and I will develop it further in the rest of my talk. So here we take the brain and subdivide it into its basic Broadband areas, its anatomically defined pieces, and look at their similarity with each other in gray matter density. So this is an 80 by 80 matrix, essentially, of correlations of 25 healthy subjects. So this is essentially a heat map of the self-similarity of the brain. The regions that are red are regions that are more similar with each other across a whole group of subjects in their gray matter density relationship between areas. And the blue ones are negative. So we're taking two areas of the brain, saying how similar are these densities in relation to each other across a group of subjects, and generating this whole map. Now if I plot that similarity as a function of distance between the areas of the brain, I get this negative correlation. So this says that basically brain areas that are close by have similar gray matter properties. Brain areas that are far apart have negatively related properties. And this is essentially a space distance relationship of the brain overall. Now, if I do exactly the same analysis in chronic pain patients, you see a very different picture. This is the similarity of chronic back pain, complex regional pain syndrome, and osteoarthritis. Just from the color map, you can see that they're different from each other, right? All three of them are a lot different from the healthy subject. And essentially, the chronic pain state makes the neuroanatomy of my whole neocortex become more similar to other people who share the same chronic pain condition. Okay, so these guys are more similar to each other than they are, etc. Now, spatially, if you look at this spatial map, this was essentially a negative slope. Here, the space is being occupied in very bizarre ways, in that the relative gray matter relationships spatially have become distorted based on, again, which regions are reorganizing in the different extents. We can, in fact, then look at this extent of reorganization as a single parameter. If I calculate as an overall global parameter of how much this brain has reorganized, and plot that on the y-axis. Now on the x-axis, I'm simply plotting each individual subject's number of years that they are in pain. Sorry, I can't read it from here, so you cannot read it for sure. This is duration in years. Each subject, how many years they had pain. This is for the chronic back pain patients, complex regional pain syndrome, and osteoarthritis. Each case, we get a beautiful exponential curve. This gives me a time constant of how long is the brain reorganizing in each of these chronic pain conditions. I don't understand exactly why these time constants are so different, but in back pain patients, that time constant is about 10 years. In CRPS, it's around 2 years. So in a sense, in back pain patients, the brain is continuously changing its anatomical cortical gray matter profile over a 10-year time period. While in CRPS patients, for some reason, that time period is much shorter. Exactly what's driving it and why, again, I cannot answer the question. But what I'm trying to emphasize here is that it's not the specific single brain area that from this that we could extract and say, here is the dorsolateral prefrontal cortex that's going to define chronic pain. I think it's this whole interaction that's changing in time that gives us a much more global view. Again, this is the global network interaction viewpoint versus the localized brain activity viewpoint. So here's my cartoon diagram of what I'm trying to show you. The brain as a network, it's reorganizing in time anatomically, and since it's reorganizing anatomically, it has to also reorganize functionally as well, right? And let me show you some of the data along those lines as well. Okay, before I go there, so I want to first spend a few slides discussing placebo and drug treatment and how the brain, in fact, can identify these things. This was a double-blind placebo-controlled trial where we were looking at the efficacy of lidocaine patch, putting the patch on the back in chronic pain patients to see if you get a benefit from it over a 2-week time period. And this is a standard treatment. I don't know if you guys use it here or not, but at least in the US, it's used all over the place. There are no clinical trials showing its efficacy. So in fact, the company that makes it actually came to us and said, will you test it? And said, yeah, sure, give it to us. We'll do the study. The end result was we saw no difference between placebo patches versus lidocaine patches. There is a decrease in pain over time, but the decrease is exactly the same amount whether you have a patch that has no drug in it versus a patch that has lidocaine. So that gave us the idea that, well, okay, here is, and in fact, if we look at the brain activity also, there is no difference in the brain activity between the active treatment versus the placebo. So this was a natural, designed placebo trial for us, and we said, so okay, if we look at these brains of these subjects, can we identify who is a responder versus who is not? So if we take this data and simply subdivide it by the median into now placebo responders versus non-responders, now I get this large difference by simply taking artificially subdividing the data. I don't care now what the treatment was anymore, right? I'm assuming all of it was placebo, and the question is, can I identify the responders from the non-responders a priori from the brain connectivity now? In this case, it's functional properties, and the answer is yes. So we end up finding, again, a prefrontal cortical area and its connectivity to the insula bilaterally that, in fact, differentiates the responders from non-responders, so placebo responders bilaterally. And now if I simply look at how well is the prediction, this is the brain now, the brain functional property before the trial had started, right? We can identify with between 80 to 90% accuracy who will respond to this placebo simply by their connectivity, by the amount of information that the frontal cortex is sharing with the bilateral insula. So we've done a similar study now in osteoarthritis patients, and I'm not going to spend much time on it, but we get a very similar result. In this case, everybody only got placebo. In fact, we just gave them sugar pills in this case. And we said, we have a drug, we don't know whether it will work or not, take it and let's see what happens. And again, we have responders and non-responders simply by amount of change. And the amazing part here is this is a 2-week treatment. The subjects are getting this pill every day. I don't know, maybe twice a day. It's just sugar, right? But the placebo responders, their pain changes from 7 out of 10 down to 2 out of 10, and that's persistent for multiple weeks. And as soon as we take the pill away, the pain returns back to its initial state. So here's a massive placebo response. And again, we can identify the brain region and almost 95% correct as to who responds and who doesn't respond simply at time 0, before start of the trial, as to their propensity to become a placebo responder or not. So at least the brain functional properties predict placebo responders. Now, in a more recent study, we were studying the effect of duloxetine, an SSRI that recently has been approved for chronic pain conditions. We studied this in knee arthritis patients, 40 subjects. Again, the company came to us and said, will you do the study? And we said, yeah, of course we can do it, but there's a danger that it may not have any effects, kind of thing. Anyway, so we did the study again. At least with this cohort, we see no difference. 4-month treatment, 20 versus 20, there's no difference in the amount of pain relief between the two groups. Okay. Again, if we take the duloxetine treatment versus placebo treatment and subdivide it into responders and non-responders, again, I can identify the two groups. And in this case, it's actually interesting. So now I have 4 groups, duloxetine responders and non-responders, and placebo responders and non-responders. If I simply look at the placebo responders over a 4-month treatment period, we can show that in fact the whole neocortical gray matter volume significantly decreases in these subjects. So placebo is not a neutral event, it's actually changing the brain. The people who are responding to placebo, it's actually changing their brain as well. Okay? And moreover, if I simply now take, again, these self-similarity matrix of the brain anatomy, we can identify the duloxetine responders, the placebo responders, a priori, just from their anatomy of their brain, and they're different from the non-responders. Okay? So both the anatomy and the physiology of the brain can identify drug treatment type, response to type of drug, placebo responders, etc. Okay, this is my little movie I wanted to play. This is actually brain activity in a single subject. It's 1/2 of the brain. It's opened up so that I'm showing it in 2 dimensions. Right? So this is the occipital part. This is the visual part of the brain. This is the frontal part, midline, temporal cortex, and so this would be, for example, sensory motor region of the brain. I have not done anything here. We've simply decreased the high frequency, so it's band passed a little bit, just so that we would get rid of the extra noise. This is a subject activity for 10 minutes, and the subject is not doing anything. Okay, this is I just want to give you the sense of how much the brain is active, even when you're not doing anything. This idea that the stimulus has to come into the brain to activate the brain is simply not correct, right? This is the resting brain activity, and the resting brain activity is now a very exciting topic in brain imaging, and I want to sort of show you some data along those lines. But before anything else, I mean, just look at this. On top of this, when we talk about a stimulus-evoked activity, it is a very tiny amount that sits on top of all of this huge, massive oscillations of the brain that's happening. Okay, and the resting state brain activity can be analyzed in many different ways. I will not go to too much detail, but we think of it as networks that are oscillating within themselves, and these networks are interacting with each other, so information is exchanged between these networks, even when we're not doing anything. And so those networks can be identified using multiple methods, either as independent components. So here's, for example, the default mode network, etc. This is a sensory motor network. Or you can identify them by a seed. You put a seed somewhere in the brain and look at what other areas it's actually correlated with. Those are different seeds. We have actually published a series of papers about the frequency content of different voxels in the brain, in the sense that the amount of oscillation of a given voxel is correlated to the network, underlying network, and to the number of connections it actually has. And a more recent approach is using graph theory methods as well. And I'm going to come back to this, so bear with me. Basically, if you actually take these networks and say who is connected to who, and what are the properties of that connectivity, you end up with a graph. And the graph properties themselves give us information about what kind of information processing is happening in the brain. Okay, so this is a figure from one of our recent papers about, again, a resting state brain activity this topic has been ongoing for at least 10 years, and a variety of laboratories have actually published resting state brain activity abnormalities in different chronic pain conditions. Here we're trying to say, okay, if I take, again, multiple groups of chronic pain patients, how different or how similar are the abnormalities? Is there a global viewpoint within which I can conceptualize what is changed functionally in the brain, in the resting state brain? So these are healthy subjects, chronic back pain patients, complex regional pain syndrome, osteoarthritis, I think around 20 subjects per group. And these are the networks that I showed you about. Again, this is the default mode network, the sensory motor network. No, that's the salience network. This is the sensory motor network here. Some attentional network, and the visual network. Essentially, if we look at all of these, the only network that we see distorted is the default mode network in this comparison. And even there, the differences are hard to see. They're small differences. And we can go on, and so this is now the default mode network across the 4 conditions. It has some small changes, and it has some different areas, components of it are connected in different ways in the different chronic pain conditions. We can see differences. Do I get any real insight from it? The answer is really not. No, not really. Right? There are differences that I don't really quite understand in general. What we do find, for example, that's constant across all of these conditions is the information exchange between the medial frontal cortex and the insula. Again, those areas keep coming up, and that connectivity, the amount of connectivity between those 2 areas in all 3 chronic pain conditions is directly correlated to their pain intensity. Each dot here is an individual subject, and in all 3 cases, that information is one-to-one linked to the. So what that says is that there is actual information sharing between these 2 areas of the brain in direct proportion of the amount of pain any one of these subjects has. And essentially, this to us is the evidence that the insular nociceptive information is being pumped into the emotional prefrontal cortex, rendering the condition more emotional in a sense. This is the sensory emotional integration of chronification of pain. Okay, so I'm coming back to the brain as a network, and I want to show you that in fact, if we look at the brain and more globally, we end up finding some even more interesting results. This is unpublished data, so bear with me, but it's coming up very soon. And essentially, we claim here that we have an actual signature of chronification of pain as a whole brain network. So again, if we think of the brain as oscillating voxels and their correlation with each other, we can generate from that some network, right? And the network is composed of nodes. The nodes, in our case, will be the individual voxels, and edges. The edges are the connectivity. The edges are determined basically by the extent of information shared between pairs of brain areas. So, and the network overall is going to be modular in that different groups of elements talk to each other more closely, and then there are connections between them. So you can think of it as having multiple modules, and then we have hubs. The hubs are in fact these critical voxels that connect different modules with each other. For example, if you think of it as airplanes and flights in Europe, Frankfurt and London will be the hubs, while Seville will be a local connection, right? In that most of the traffic in Europe is connected through London and Frankfurt, and if you degrade London, or if Air France pilots go on strike in Paris, the whole network traffic dramatically changes. On the other hand, if it happens in Seville, the effect is much smaller, right? So that's the general idea, in fact, is exactly what we are discussing. And the role of the hubs versus local connectivity and their interrelationship and how those things change with chronic pain is what I'm trying to discuss. Okay, with that introduction, so in fact we literally do this in our chronic pain patients. This is again all resting state brain activity. We take a 7,000 by 7,000 matrix. This is now 64 million connections of the brain, okay? And pare it down to a fixed density connection, so we end up with a picture like this. And then for every given node, we calculate its degree. The degree is simply how many people it's connected to, how many people it's talking to. And then we're going to compare this between patients and healthy subjects and see what the difference is. Okay, so sorry again. My slides got messed up, so I tried to put this back together. So what I'm plotting here is on the x-axis is degree of healthy subjects. So it goes from 0 to 1600 in a sense that any given voxel in the brain can be connected either to nothing, 0, or up to 1600 other voxels. So at the peak here, these are the hubs. At the bottom here are the small nodes. And on the y-axis, I'm taking the difference, the group average difference, voxel by voxel between the healthy subjects and the chronic pain patients. So this is essentially a 7,000 point correlation plot, right? Each dot shows whether that dot changed in its connectivity between healthy subjects versus the chronic back pain patients. And the slope here is about minus 0.3, which basically says that overall, throughout the whole brain, connectivity overall has changed by 30%. 30% of the hubs have lost their connectivity, and 30% of all the small connections have gained in their connectivity. Okay? And the blue points are all the hubs that have lost. Those are statistically significant regions. And the red are the brain areas that have gained in their connectivity. So there's an overall balance. The brain connectivity is sustained, but many of the areas of the hubs have lost their connections, and many of the smaller areas have gained in their connections. Now we can calculate that for each subject as well. And sorry, again, each line here is an individual subject. So for each subject we can get a slope. Now if I plot that slope, which is my y-axis, versus the pain intensity of each subject, we see that the hub disruption, the overall whole brain hub disruption, is proportional to the intensity of the pain of each subject. Okay, so it reflects the amount of pain that they have. Okay, so this is in fact the same data. Now I'm showing it for, this is the chronic back pain patients. This is the hub disruption for about 25 chronic back pain patients versus healthy controls. That hub disruption, each subject and their pain intensity, there is a very nice correlation. The same is true for complex regional pain syndrome. Again, their pain intensity correlates with their hub disruption. The same is true in osteoarthritis patients. And again, we see a negative slope and a very tight correlation, in this case with WOMAC, with their hub disruption. So across multiple chronic pain conditions, we see a very similar scale of hub disruption. This is overall connectivity of information sharing in the brain. That amount of connectivity change is proportional to the amount of pain that they have. And these are the actual areas. I don't want to belabor them, it gets too complicated. But again, I can generate now a similarity matrix across all of these subjects. This is now the OA subjects, CRPS, and chronic back pain patients. The overall spatial similarity of the hub disruption. And what we can see is that each group is fairly homogeneous and quite different from each other. So the hub disruption overall, globally, is similar. Spatially, is specific between subjects, between types of chronic pain patients. And in fact, we can now show the same thing in rats. These are anesthetized rats who have had a peripheral nerve injury, and they show pain behavior. Under anesthesia, 28 days after the injury, again, we see a very nice hub disruption, and the disruption is again proportional to the tactile allodynia, the amount of touch sensitivity these animals show, even under anesthesia. Okay, so I'm going to stop my talk here, and we'll pick it up later. And here's my overall summary, that the classic Cartesian viewpoint is that information travels from the bottom up, and that in fact chronic pain is simply keeping this thing up going for a longer time. Instead, I've shown you at least two different colors of brains, right? Different types of brains, and in fact we think the interaction across the whole network is the critical problem. How do these changes happen? I have not addressed, but stay tuned. In the next hour I will discuss that, okay? Thank you, I'm done.